Right, I think it's a few minutes past one, so we'll make a start. Shelley, are you still there?
Yeah, I'm still
Yeah,
here.
brilliant. Okay, you're the main person in all this, so just checking that the audio's working. I'm just going to do a short introduction and then hand over to Shelley. So, welcome everybody. This is the first in hopefully a series of these kind of webinars where we're exploring how an active partnership has tackled working within a particular system. In this case, trying to embed sport and physical activity into the health system in Norfolk. So thanks everybody for joining us, taking an interest. Thanks particularly to Shelley from Active Norfolk, who's put the case study together and is obviously doing all the work at a local level. So the idea of today's session is to share practice, obviously, in this case, that the work that's going on in Norfolk. Um, we're also particularly interested in answering the question around how do we show impact as a strategic enabling organisation relative to the work that you're doing. So that's a purpose of this case study work. And if you are joining us via the web link, you should, if you can share this, if you can see the screen, you can see the strategic outputs. Now, these were created as part of the PMAF Quest process to provide an illustration of how an active partnership could demonstrate its strategic impact. So that didn't particularly come out that well within the Quest process. So since then, we've been trying to think about how we might give it a bit more profile. So you'll notice that within the case study, there's a strategic impact section, and that follows the strategic outputs, the ones that are listed on your screen at the moment. So hopefully, I think it's been quite useful for Shelley and the team in terms of providing that narrative, that structure, that story in relation to this particular case study. And hopefully it will be useful for others as well. And as well as using it to demonstrate impact, we're also keen that it's used as a planning tool. So these things become more intentional as part of a project or a way of working at the start rather than just relaying them at the end. So that's a big part of what we're trying to do to help individual partnerships to demonstrate impact, but also when you put that together across the whole network, if we're all doing this kind of thing in a fairly consistent way, then it will help to show network impact as well. So that was the thinking behind it, and we're hoping that we're hoping to build up a compendium of these kind of things. So this is a call out to anybody on the call. If you've got emerging practice, emerging impact along these kind of lines, then please get in touch with me and we can work together to work up a suitable case study. The idea as well is that it's not just one way from Shelley. So we know that this won't be just isolated, and there'll be lots of practice going on in the network. So when you get a chance to speak, if you've got any learning from your particular practice, then please share that as well. So those were the key things. We did it in a webinar form because we're conscious that Shelley's been kind enough to spend the time to put all this together. We didn't want her to be inundated with lots of individual emails and phone calls, so we thought this would be quite an efficient way of bringing it all together as well. I mentioned at the start that we're recording this, so hopefully that's okay with everybody, because there were one or two people who couldn't attend today but wanted to replay afterwards. So that's the idea, that it becomes a bit of a resource for the whole network. So just quickly then, in terms of housekeeping, we've got the written case study, which hopefully everybody's had a chance to look at and digest, and we'll be following that. We'll we'll ask, Shelley's just going to introduce it section by section, not read the whole thing, but just keep to the key highlights. And after each section, we're then just going to open up the mics, and then if you've got any questions or you want to share any practice from that particular section, then that's your chance. If you could keep your input fairly short and snappy and concise, we've got 13 people on the call, so let's see if we can get through it in a fairly efficient manner, and then we'll just repeat the process and go through each section like that. So that's the idea. Shelley, is all that okay with you, and are you ready to go?
I am, yep.
Yeah.
Ready to go.
Okay, so I'm just going to switch over to the case study. So I've got a case study. So yeah, Shelley, over to you.
Okay, so as Adrian said, what we thought we'd do is just flick through each section and then open up after each section rather than doing kind of an overview of the whole thing. So I was going to start with the kind of rationale and a bit of the context behind the work that we've been doing. And apologies if some people have been to the convention this year. Some of this might be covering old ground, but obviously we haven't captured it quite in the same way. So we've had a relationship with public health locally for a number of years. We initiated with the PCT, as it was back sort of 8 or 9 years ago, a shared role between Active Norfolk and Norfolk and Waiting PCT, and that role was focused quite on sort of embedding projects, exercise referral, kind of a project coordinator type role, and it's evolved over time to be a bit more strategic and a lot more focused on kind of the broader health outcomes. But it has always been really focused on how we support public health in achieving their outcomes. And back in the summer last year, with and kind of a lot happening in our system, as it will be nationally, around kind of a move into an integrated care system, the SPPs coming forward and gaining more traction locally, we decided that we needed to build our understanding as an organisation about how we might work better in the broader system beyond public health. So we wanted to move what was quite a transactional relationship with one of our CCGs. We've got 5 in Norfolk, so we've got one 2-tier authority system, so 1 county council, 1 public health team, 5 CCGs, although they are now moving to a single management structure, which I think will make things easier. But we had a really strong relationship with Norwich CCG, so we started there because we had quite a good foundation, but it was quite transactional, i.e. they'd given us quite a bit of funding in the past to deliver activity. But we went to them with a proposal to put some of our strategic capacity, so some of my role, into spending a day a week with some project officer support time allocated as well, into spending time to really understand how we might embed physical activity into their world. The initial proposal was to do 6 months of kind of scoping with them. It's ended up taking quite a bit longer than that, and obviously the strategic landscape has shifted quite a lot in that time. So in that time from when I started that work last August, we've had the prevention vision launch and the long-term plan launch as well, both of which have actually been really helpful because there's been an increasing emphasis on prevention. So it's really helped us to kind of land what we're doing and for the CCG to really have an appetite to engage with us. So that's kind of the context behind it. Really, it was about building our understanding and trying to understand where our business as usual might be able to support the CCGs to achieve their outcomes. And I guess a point from the start really is that it wasn't about, although it has happened, it wasn't about the identification necessarily of new resources. It was more about how can we align the things that are already happening and make them more efficient. How do we align the resources that we already have and support each other to achieve our outcomes? So I think that's kind of a summary really of what you will have read within the case study. So I don't know, Adrian, if now's the point we want to flick over on that part. I'd be really interested to know if there is, our examples nationally of anyone else doing this work, because of this happening.
Sorry, carry on.
No, it's okay.
I pressed the wrong button.
So certainly from my perspective, one of the reasons I suggested a kind of the webinar format is that I'm quite keen to kind of understand where I might be able to, you know, some people have read the case study and thought, well, actually, we're doing quite a lot around this space. And, you know, maybe even, I know there are examples, I've spent a bit of time with Dorset recently, and I know there are examples of some of this work where it's actually further progressed than what we've done in Norfolk. So really keen to kind of learn as well as answer any questions that anybody might have.
Brilliant. Okay, thanks for the intro, Shelley. And as we said, we're just going to open up. I think most people are self-muted here. I think I pressed the wrong button. So we're now going to open up for questions. We're going to do it section by section. So if you can keep fairly disciplined. So at the moment we're looking at, you know, the rationale. Why was it a priority, and the context that Shelley was working in. You can restrict your questions for that for the time being, and then you'll have a chance to ask questions about the other things later. But is there anybody who's got any questions so far? Everybody's kind of self-muted here, so I'm hoping that that's not because you're not able to speak.
Hi, it's Lisa here from Westport.
Oh,
Can you hear me?
Good. Yeah.
Hi. Hi. Just a quick question, Shelley. Really, just a little interested in a little bit, maybe a bit more detail in terms of the paper that you submitted. Sort of what was the context of that? Was this a big document that you submitted, or was it very much sort of looking at kind of, I suppose, that national evidence review about why you thought this work was worth them spending the time on having you do this sort of scoping exercise? Sort of how much detail, I suppose, did you have to go into in that paper?
Sorry, the sound's not brilliant. Do you mean the paper that we submitted to the CCG with the proposal back in August? Like
yes.
What kind of information we provided at that point?
Exactly. What sort of information was in that? Yeah.
Sure. So we talked a bit about, really, we emphasised within that the shift in our kind of focus and the move away from kind of, you know, previous core funding for Sport England, and the fact that the national strategy now is much more focused on a wider set of outcomes, and that we needed to build our understanding up of those areas of work and how we might best work within that system. So a lot of the, I'm just trying to find actually the brief that we sent, and it's certainly something that we could that we can send round, but it was very much about proposing a partnership approach that built on the foundations that we already had. I'm just trying to think about the actual strategic context that we put in there. We talked a bit about our mandate and the role that we have for Sport England, and the work that we do around insight, and that we're looking at population level data and trying to kind of ensure that what we do in terms of landing our resources is reflective of local need. And obviously there's a massive need in Norfolk, as there will be in other areas, around certain population groups. So we certainly talked about that in that initial proposal. And we talked a bit about some of their emerging agendas at the time. So at the time, all the work streams that from the SPP's perspective were starting to emerge around diabetes, primary care, and obviously a lot's happened in that space in the last 12 months. But at the time, they were quite emerging agendas. So we talked about the fact that we thought that there were opportunities to embed some of our work within some of those work streams. And we kind of listed within that what work streams were applicable and where we felt there might be opportunities. And I think what we were proposing to the CCG was a joint exploration of that, rather than us looking at those work streams and then coming up with the solutions and telling them what we felt we could do. What we were saying to them was, let's take a step back and look at them and collectively see where there might be synergy and where there might be opportunity to work together. So because we were building on an existing relationship, we didn't have to go into too much, I don't think, in terms of that background, because they understood quite a lot about us. Now that I'm going to scale up across the rest of the system, we don't necessarily have that strength of relationship with some of the other clinical commissioning groups. where the single management structure is going to be helpful. But I certainly feel that in trying to engage a couple of them in particular, we're going to have to provide a lot more background and a lot more context as to why we're kind of getting involved in this space. Because just sort of saying, well, we've done this in Norwich and can we do it with you isn't enough. So we're trying to build an understanding of what we are and what we function to do in as an organisation and what our primary role is. And I think that's really, we can really see evidence with Norwich that their understanding of what it is that Access Norfolk does has really grown in that last 12 months. So I'm not sure, hopefully that's answering the question. I'm more than happy to share that initial proposal that we sent in, if that helps anyone.
Yeah, no, that's really helpful, Shelley. I mean, our situation here is, we don't have any relationship with CCG and certainly not at the exec level. So we would be coming in cold. So that's really helpful to, to understand sort of the angle that you came in and really getting them to understand what our role is and very much that focus on it being a joint effort. Yeah, that's really helpful. Thank you.
Thanks, Lisa. And Shelley, if you can get that paper to me, I can circulate it with, after this webinar, so everybody can get hold of that.
Sure.
Any other questions before we move on? Linked to the context, the rationale? Nope. Okay. I'm sure other things will come up. So back over to you, Shelley, and we're going to look at the process and the key milestones.
Sure. Have you got that process in front of you, Adrian?
Yeah.
Thinking that it might be useful to have that up.
Yeah.
Obviously, this was shared, but people may have focused on the case study. So what we've tried to do is capture, this rather messy document, which Ben has told me we shouldn't be sharing because it is a bit of a mess, and he's right. But this is the starting point. I don't think he means across the network. It was more about sharing it across the system here locally. What I've been trying to do is capture the steps that we undertook with Norwich, because we have been asked to scale up this work across the system. So I've been really trying to think about what the kind of critical parts of the process were, and in how I'm presenting it then to the rest of the system, I'm trying to present this and then present what the critical kind of success factors were with regards to the Norwich work. I mean, it's yet to be seen how much of a success that work's going to be. It's still quite early days in terms of implementation, but we've really tried to just capture the process so that we might be able to replicate it. And we've recently had a conversation with social services locally about how we might repeat this process. And I think, we'll start to get feedback from this at a system level into this process and whether it's replicable. But I think the key bits really were that we got that mandate from senior leadership to undertake the work, and that the initial proposal wasn't about any kind of investment. It was literally, can we take a step back and take some time to look at where there might be opportunities? So all we were asking the CCG at the time of the proposal to commit to was time. We were asking them to allocate a senior member of their team to work with me on this. They weren't giving a huge amount of time to it, but they obviously understood. What they did was allocate their head of planning, not head of planning like we would see in local government, but it was someone that understood all the different work streams of the CCG and held all of the kind of contracts and project initiation documents. So someone that had a really good oversight over everything. And they were then able to plug me in to the right people. So getting that mandate from the exec and getting the right person involved from the start that had that oversight was really key. We then, over a couple of months, actually took some time to really brief the team within the CCG so that they understood why I was going to be there a day or two a week, what we were going to be trying to achieve, some background information around physical activity, its importance, how it contributes to CCG outcomes, that kind of thing. So we spent a bit of time doing that, giving that background. What I wish I'd done, in hindsight at that point, would be take a baseline of the understanding levels around physical activity, and we didn't. But I think it would have been really helpful to have baselined workforce within the CCG at that point. One, to understand what they knew about Active Norfolk, or what they thought they knew, and two, to understand what they saw physical activity's role being within the work that they were undertaking. So that's why we've embedded it into the process, for if we're going to replicate it, doing some kind of baselining at that point. We then went through with the senior level team, we went through all the different areas of work that the CCG were involved in, and we discounted things where we felt there wasn't necessarily even a tenuous link to physical activity. So things like dermatology service reviews and, where there's no evidence base that physical activity can have any kind of impact. But we then ended up with quite a big pile of work, project initiation documents, contracts, that kind of thing, for areas of work that we knew physical activity might somehow have some sort of link with. We then followed up with all of the program leads or the commission leads or the directors, whoever had kind of lead role in those programs of work, and spent time with those staff members to really unpick their areas of work and collectively come up with some opportunities really for how we might work together and how we might embed physical activity into what they're doing. And at the same time, we started to identify some of the appropriate team meetings, directorate meetings, areas that I might plug into so that I didn't have to keep meeting everybody separately, but, platforms where I might engage with everybody in a group, and where I might learn a bit more about how the CCG operates on a kind of day-to-day level. All of the opportunities we identified, we put into a log, we did a SWOT analysis collectively, and we repeatedly updated the governance team. So we went back at kind of different points with the exec with updates about how we were progressing and what the key themes were that were emerging, that kind of thing. And I think the last thing that we did was probably one of the more important things, which was we took that long list of recommendations and we sat down with the directorate, with a number from different levels, a number of the team, to actually do a prioritisation exercise where we compared the impact of each of the recommendations against the resource requirements and whether those resources already existed. So it's almost like the feasibility really versus the impact that would happen, that it would have. And what we then were able to do was narrow quite a long list of recommendations down into a much smaller list that went back to the exec for their endorsement. Now, we've been really open with the CCG from the start that, where there were resources available or where perhaps we could put some resources in, but maybe not enough to do anything at scale, and where there wasn't the existing resource. And as a result, I won't go into the next bit yet, but as a result, we were able to put forward recommendations to be really clear on whether we were going to be asking for investment or not. So they were the steps, and I think the key bit really in terms of the critical success factors were around getting that buy-in from the senior level, but also collectively coming up with those recommendations. So I don't think it's felt at any point that it was Active Norfolk going in and recommending to the system what they should be doing. The recommendations were collectively and collaboratively pulled together, and when they went to the exec, they came from both the CCG and Active Norfolk. So there's a certain amount of ownership over the recommendations that were put forward, and in terms of now the realisation of those recommendations, we have real ownership within the CCG, and we've started to allocate leads against each of the recommendations so that we really have a clear kind of buy-in from each of the teams. So I think that's it from the kind of process, and in terms of the milestones, we put those in really as an indication of how long, and trying to be realistic about kind of how long this process has taken. When we first went to the exec, we kind of offered my time for 6 months, and that was back in August, and I submitted the report in May. But bear in mind, I guess, that this is only quite a small percentage of my role. We didn't allocate my whole kind of job remit to this over a period of time. Obviously, if I had done that, it would have taken a lot less, but I'm sort of juggling quite a lot of other things at the same time. So yeah, if you can see on there kind of roughly how long things have taken to get underway.
Brilliant. Okay, thanks, Shelley. So we've covered the process and gone through that process map, and you can see the key milestones there. So that gives you a flavour for the kind of work that was done in what order. Any questions? Again, just open up to ask if there's any questions around those two areas. I think they're waiting for the big impact one, Shelley.
Okay.
Okay, so let's move on to system map and narrative.
Sure. So, I mean, this, to be honest, the system map here has changed even since we submitted the case study, and I think that probably is just reflective of the pace of the system at the moment and the changes that are happening within the NHS, both nationally and at a local level. But the key work streams here still exist. So this was a representative of our system locally. As I mentioned, we've got quite a lot going on at the moment around 5 CCGs coming together at the moment under a single management structure, but I think it's quite clear that they're going to be one CCG within the next couple of years. But under each of these work streams, there are kind of governance frameworks for primary and community care, mental health, and the rest of what we've done with the CCG is obviously from Norwich's perspective, they will be one part of the bigger picture here, but they will be plugged into each of these areas of work. We'll have responsibilities within each of them, whether they lead on them on behalf of the system or they're just contributing. So as part of the process, we've picked apart these different work streams and looked at where there might be opportunities, and there's a lot of common threads that underpin this. And actually, a lot of the common threads on this governance structure here around comms and engagement, workforce, are similar to the recommendations that we've identified as well. So what we try to do with these work streams is kind of look at the changes that were happening and where there might be opportunities. So to give you an example there, our mental health services, both adults and young people, are currently being redesigned, and there's been a new mental health strategy developed for Norfolk, which has a number of work streams under it, one of which is prevention. And we know that obviously a big part of the prevention agenda can be and should be physical activity. So what we've been doing is working with that work stream and getting into it with our Norwich counterpart, our Norwich colleagues, to really understand what our role might be, first in the implementation of that strategy, but also where we have kind of existing resources for delivery around workforce or programs or project funding that we do already have, how we might align some of those to achieve some of those outcomes. So that's kind of the governance, and I think, you know, it'll probably look quite similar in most areas, but obviously work streams will be different. I think it's just about understanding where the opportunities are under each of those. So in terms of impact, I use that frameworks that Adrian put up at the start of the call. So we talk about insight and on different parts that we'd want to be evidencing. And I think it's fair to say that we're only in early days. We only put the recommendations through to the exec in May. So we're still looking at now the realisation of those recommendations. The exec's feedback was that they endorsed all of the recommendations. What they wanted to do, unsurprisingly, I guess, was look at the recommendations we've made where there was some existing resource first. And then they've asked us to put forward a number of proposals for how some of the others might be taken forward. And subsequent now to being asked to look at a system-wide version of this work, we've now been asked to look at system-wide versions of those proposals. So we've done quite a lot of work in the past, for example, around care homes, and there's quite a lot of work coming through the long-term plan around enhanced health in care homes. An investment that will be coming to all counties in about 8 months' time. So we've been asked to develop a proposal for the system for how physical activity might be embedded into care homes across the whole county. Initially, the recommendation was to build a proposal for Norwich, but inevitably there will be these questions now, particularly with the merger happening, about, well, actually, we don't just want to look at it within one place, we want to look at it within the whole system. But I think the key bits for us was alignment of insight. We obviously have access to certain insight sources, the ones that are publicly available. We work really closely with public health. We're very fortunate in that we have a full-time insight and evaluation officer that works for Active Norfolk, who has a background as an academic background, but really understands the data. So we've done quite a lot of that kind of pooling. What the CCG have a lot of access to is the data that comes from primary care and that comes from the hospitals. and they present that in ways that helps them to direct their resources. So keeping on top of their insight and their business cases for investment. So, for example, quite a lot of data at the moment around emergency admissions for our hospitals are pointing to real issues around falls, significant issues coming from care homes, again, underpinning the care homes proposal. So it's about those kind of sensible uses of the data and really looking at what they're scrutinising, because quite a lot of what they're scrutinising, I think as a sector, we potentially have some answers for. So diabetes data is another that's really being scrutinised at a CCG level at the moment. So us understanding what's important to them in terms of their insight at the moment and what they're looking at is quite helpful in terms of how we then shape up any proposals or any business cases for why they might invest in physical activity in the future. We've got a greater level of insight as well, I think, into the role that we mentioned strategies, but there's been a lot of strategies released locally recently, and there's new ones that are being developed at the moment around prevention, the prevention strategy for the county and a frailty strategy as well. So I think it's about, you know, that insight not just being about the data, but also insight into what our role might be in the future. Advocacy has been a key bit of impact of this work. I think having advocates that are now elsewhere in the system or that are able to influence other parts of the system is really useful. So really building that understanding and spending that time with just one organisation has had a much knock-on effect in terms of our influence over other partners. So whilst Norwich is just one, as I said, of 5, they work across all 5 CCGs to achieve the SPP outcomes. So we're already kind of infiltrating some of those areas of work. They have a really good relationship with the provider networks, so the Foundation Trust for Mental Health, the community nursing teams, the acute hospital, all of which, again, you know, there are opportunities to work with them around some of our existing areas of work. So I think, you know, we put all our eggs in one basket, but I think building relationship and rather than trying to spread myself really thinly over trying to, you know, build lots of shallow relationships with lots of different organisations, really putting some time into one, probably at the detriment of some of our other relationships for a bit of time, has really helped, because they may be more responsive, I guess, to senior leadership within the CCG talking about some of the work we're doing, rather than actually Norfolk having that conversation ourselves. So we now feel that we have that network of kind of advocates. It did result in investment. I guess, you know, it was an inevitable part of the process that we were going to need some investment at that point, and I think we've always been honest with the CCG about that. It wasn't about a cap-in-hand exercise. We weren't going to them for investment specifically, but they do have investment for particularly, you know, long-term conditional offer, a number of things that align with these recommendations. So there are a lot of opportunities, but I think it's about being clear from the start that we're not, you know, penniless organisations. We do get investment, and we do have access to national investment streams. And actually, we've been working with the CCG on some joint bids since this, because we feel that we're in a much stronger position to apply for external funding than perhaps we were just going at, you know, at it in isolation or on our own. And I think the policy bit is, I'm hoping that's the area where we'll have the greatest population level impact in terms of the work. So there is a lot of work happening, certainly in Norfolk at the moment, around redesigning services because of the alignment that's happening within the system. So we've got mental health service redesigns going on. We've got musculoskeletal redesigns going on. We've got pathway redesigns around diabetes, around the acute hospitals, work around cancer happening. And, you know, and all of these processes provide an opportunity to consider physical activity, you know, as part of a pathway for somebody who's been diagnosed with a long-term condition, for example. So one of the things we've started to look at now with the CCG is the checklist that they undertake when they commission a new service, and whether we can put physical activity as a consideration on those checklists. Sometimes it might be considered, and, you know, as I mentioned the dermatology example earlier, it might be mentioned and be completely irrelevant and they just tick the box to say, yeah, we've considered it and it's not relevant here. But at other times, like with the MSK contract, there is so much opportunity to embed a link with leisure operators or with exercise referral or existing things that are happening, to embed that within service design. So in hopeful, if we can get it as part of the standard process that a CCG takes, then we can start to really have an influence on those services at the design phase, rather than what we often do, which is wait for a new contract to be awarded and then desperately try and work with the new provider of the diabetes program or the physios locally and try to retrofit physical activity to what they're contracted to do. And there's no performance measures in there for them to deliver physical activity. So nothing really for the system to hold them to account. There's nothing for us to kind of really use as a way to influence their delivery. And I think the biggest area for us has been workforce. The STP are writing a workforce strategy. There's a huge emphasis within that strategy on workplace health and well-being of the NHS staff. We've had lots of conversations about role modelling and the importance of role modelling in terms of the workforce. And we can't expect them to have physical activity conversations if they're not confident about their own health and well-being and lifestyle choices. So a lot of conversation about health and well-being, which will be linking for them to retention and mental health and some of those other areas. Quite a lot of conversation about diversification of roles as well. So how can we make roles within the NHS a bit more enjoyable, a bit more, give people a bit more satisfaction. And some of the work, again, we've been doing in care homes are things like training care home staff to deliver really low-level seated exercise, and that's something the system are really keen on. How do we get our social workers that are going out into people's homes to recommend physical activity and provide some practical tips for people to do exercise in their own home? So we're looking at how we embed that kind of workforce development that we do into the workforce strategy for the NHS moving forward. So I think I'm hopeful that that's an area that we can have, again, quite significant impact in. And it has influenced delivery. It's only just starting to influence delivery, but there has been some investment in some pilots locally just to test some of the opportunities that we recognise. So we've got one there linked to primary care networks. We've got another test or pilot likely to happen around musculoskeletal, and another one that we're looking at the moment around pregnant women. So, there are little bits of investment now that are starting to be realised as part of this process, but I think it's going to be a while before we see any significant investment, particularly given all the changes that are happening at the moment.
Excellent. Okay.
I think that's it on impact.
Yeah, and there's clearly loads going on there. So you've covered quite a lot. So let's just go back to the participants on the call and just ask whether there are any questions around impact. And there was also something there at the start around system map and narrative. So, any questions?
Can you hear me?
Hi, Henry. Yeah.
Yeah. So my question initially relates just to the things you've been talking about, but in general, what information did you need to have prepared in advance of approaching the STP? For example, did you already have a comprehensive
directory of physical activity for certain long-term conditions and that kind of thing in place?
Sorry, Henry. I can't. I don't know if you're picking this up by your agent, but I'm not.
Yeah, it was a bit fuzzy. But what kind of information did you need in advance before you approached the STP? There was something after that I didn't catch. Just repeat the last bit of the question, Henry.
It was whether you had, for example, a list of appropriate physical activities for each long-term condition already in place.
No, that's quite a difficult one, to be honest. I think what we've tried not to do and what we've tried to stray away from is going forward with any solutions, because I still think, and I don't know how others feel about this, there's still quite a lot of uncertainty for me about exercise referral and its role, and whether we, particularly when we're talking about long-term conditions, whether we need to really be presenting long-term condition-specific solutions, or whether we should be just signposting people into mainstream activity, or leisure operators and how we influence their provision. And I think at the point of engagement with the system, obviously we have that information kind of back at the ranch. It was more about identifying the opportunities in the work that they're doing. So somebody that's working on MSK, we're going to be redesigning the service, and these are the time frames, for example, that we're going to be doing that. And then what I was then able to do is go back to the team and have conversations about what the most appropriate ways to respond to those are. So, we then had conversations about escape planning, and we've been able to talk to other parts of the country, active partnerships that have been involved in implementing escape planning as an initiative. But I've been quite careful, I think, deliberately careful not to go in with the solutions, because I don't know that we always have them either. I think, some of the real easy, quick wins have just been about, creating a link between a project that's going on around mental health that isn't physical activity orientated and the local leisure operator, because actually the leisure operator is really keen for them to come and hold parts of their offer on the leisure operator site. And then, they then evolved that into talks around, and taster sessions and trying to encourage membership. The pulmonary rehab services locally are being redesigned. One of the best delivered services we have in Norfolk is in Great Yarmouth, and it's being delivered on the site of a leisure operator, and it's got the best retention rates out of all of the pulmonary rehab. And none of the other areas are being delivered in a leisure operator setting. All of them are being delivered in community settings or the hospitals themselves. So what we're looking at in that redesign is where we could relocate the other pulmonary services into local leisure operator facilities, and how can we help the system to do that. So I think really those solutions have been co-developed, and I've used NICE guidelines, and I think the one thing I would say before going to the SDP was particularly when you're looking at cancer or diabetes or any of the specific work streams, because I made sure that I was really clear on what NICE were recommending, because the health system is going to fall back on those kind of clinical guidelines. But I think there is an understanding and acceptance that we don't always have to go for those evidence-based responses anymore, and that actually that there's been quite an appetite to try new things, because the very formal referral routes aren't fit for purpose for everybody. So I hope that answers the question. I think it's just about trying to shape those solutions up, and it is quite case by case, and hopefully we'll get a bank of solutions as we go, whereby, pregnancy comes up in another area, we've got a tried and tested model that we can then land into another place, and maybe just tweak the way that it's landed to make sure it fits local outcomes.
Great. Okay. You okay with that, Henry?
Yeah, thanks very much. That answers my question.
Brill. Okay. Any other questions?
Yeah, it's Louise here from Kent. I've got a quick one, I hope.
Hi, Louise.
Shelley, hiya. Shelley, have you done any with your work with the CCG? There's two questions. One is, have you been involved with public health? I mean, you've obviously got great links if you've worked from the days of PCTs, but because with us, I don't know, it's probably this, I don't know nationally, but with us, the Public Health commission a certain number of services and CCG commission others, and one of our challenges is at the delivery end, as the customer, there are so many different organizations delivering so many different services and often targeting the same person. So I wonder if have you done anything around matching that together, because our CCG sits quite separately from public health, obviously.
Yeah, it's been an issue for us. There's a bit of disconnect between the two, and I think so. My role is part funded by public health, so in all sense and purposes. So the way that we work locally is Active Norfolk takes the physical activity role on for public health, so they don't have any public health officers that lead on physical activity. So that's kind of me. And I work between the two organisations to an extent. I think there's a bit of disconnect between public health and RCCGs in that obviously public health have had a very long-standing role around prevention. The CCGs are now starting to get a bit more of a mandate in that space, and I think there is the potential for duplicate investment going in. So I think that part of our role really is to understand where there's mutual benefit to bring kind of public health and the CCGs together and to try and influence that. Our public health team don't really invest in physical activity from a commissioning standpoint, as in direct delivery. They don't really commission many services at all now. A lot of their role is much more strategic, a lot more probably in line with the way that we're now working, and they've stood back really from delivery of services. So they've just made the decision not to fund an integrated service model in Norfolk. They are going to spend the resources they have for healthy lifestyles on a system approach, which, like ours, is looking to influence the system. So train up the workforce, try and get them to talk about healthy lifestyles rather than parachute in a service that does that for them. So it's probably about understanding both. Absolutely, public health were a key part of the picture. I think for us, we had a really good, we're quite well embedded in public health, but because the link between the CCGs wasn't always there, it was really important for us to broker that relationship independently, because I didn't feel that by going through public health was going to be the way to position. I'm trying to be a bit diplomatic, but with the tensions between the relationships a bit locally, we needed to build a separate relationship that was separate to public health with our CCGs, as opposed to relying on public health to weave us into that. I think that now we're actually able to work the other way and influence public health back, because we have a better understanding of what the CCGs are up to and where they might actually invest in the prevention agenda. Whilst public health budgets locally are getting more and more squeezed, there's more investment available within the CCG landscape now to do some of this kind of preventative work where our work sits. So, I think that public health will look more to that part of the health system and trying to influence where their investment goes so that it aligns with that prevention agenda. Does that even remotely answer your question, Louise? I'm not sure that
it does. I mean, I'm kind of reassured because our public health don't invest in physical activity either. I mean, we have a relatively good relationship with them, but when it comes to commissioning, when we're working with one CCG and there's public health have commissioned postural stability and the CCG have commissioned falls prevention, when you say, well, who are you targeting? They're both targeting the same people. It's, and then we're talking to GPs and they're saying it's so complicated. And then, that's quite apart from who's delivering the service or services that are targeting the same people. So I think it's just very complex, and we've kind of almost, I mean, we're not ignoring it at all, but because that's quite tough and takes a lot of time, what you've done in terms of one of our projects, we're trying to sort of talk to the actual delivery level, so the actual practitioners, and we have found that we've been using tools like Moving Medicine to share with them to try and raise their understanding of, especially around the long-term conditions, because obviously Moving Medicine has those specific information sheets, and that's been quite useful, but it doesn't necessarily lead to, action, because the strategic stuff, the strategic guidance isn't really there, and they're not being told to do it. They might like it, but they might not actually do it. So we're kind of gone a little bit bottom up as well, but that's because
I think it needs to be both, though. I think we've put quite a lot of resource in that bottom up approach, and I think that's part of that. And that's going back to Henry's question earlier in terms of, whilst we haven't presented many solutions around direct delivery for certain population groups, what we have got is a bit of physical activity awareness training, a bit of a workforce budget aligned with our work delivery plan that could target frontline NHS or health and social care workforce. So I think there are some solutions, obviously depending on how you work as a partnership. I think the fact that you are already engaging with frontline workforce and are probably learning from them will help to have those more strategic conversations, because you're able to say this is something that we are already actively doing, but maybe it's not as at the scale that it could be delivered, or maybe it's just not as efficient or effective, or it's being, because it's bottom up, you're probably spending quite a lot of time trying to build those relationships with frontline workforce, rather than someone from within the system, you know, that actually saying, here's an opportunity and you should be getting involved in this, or embedding it into CPD plans or whatever. So I think doing both ends, if you've got the capacity to do it, I think is important, because you need something to demonstrate what you're doing. And I guess in terms of, you know, just trying to understand your provider landscape, even if you don't understand the health landscape, if you understand the provision that's already out there, we have that similar level, you know, with falls and all different, you know, service exercise referral for us is a nightmare. It's not consistent across the county. It's really disparate. But at least we know, and we're able to say to commissioners, we know that, you know, that it's not consistent, and then it starts to become a bit of a problem, because they can't have a consistent offer. And I think it's just about understanding the landscape in the bit that we're good at, and then working with them to work out how we might match the two things together.
That's great, thank you. Yeah, it sounds like we're kind of trying to do the right thing. Thanks very much.
Thanks, Louise. Any other questions? Just a quick one from me, Shelley, while people are thinking about it. So obviously you're working in quite a systems-based way now, and trying to influence at that kind of strategic level, so that you're in a position where you can get involved at a very early stage of policies and pathways and starting to design things in. When did that kind of occur to you? Was that always the way? Was that always part of the master plan, or did it just kind of occur to you as you go along that, you know, that way of working is the best approach? Do you see what I mean?
Yeah, I do. No, I think, in all honesty, I think when we started it out, it was about how can we try and influence some of the investment that the NHS might be able to put into prevention agenda, to do more of the kind of delivery of projects and programs. You know, probably not we wanted to deliver them. It was how can we influence commissioning, I suppose, but more influence commissioning as in try and encourage more of it, more money going into physical activity, as opposed to the actual systems that might lead to that. And I think, you know, public health has done a lot of work for a number of years around health in all policies, and that's something that's been in my mind for quite a long time. And I think what became quite apparent is, whilst the CCGs have a lot more in, you know, resource than public health or other parts of the system do, potential for it, they're still not necessarily, you know, enough, and it's never just going to be freed up for physical activity. Well, not never, but it won't always be freed up for physical activity in its own right. So it needed to really be embedded into the other work streams and become part of something bigger. And I think if we were going to have a population level impact, it was quite clear that just by funding ad hoc projects and programs in Norwich was never going to really impact at scale. So I guess kind of halfway through the process, talking to some of the commissioning leads, the directors of commissioning, and then starting to really understand those commissioning processes. When you look at their equality impact assessments, for example, there's numerous questions they have to ask themselves about considerations when they commission a service or when they develop up a service spec. So you really, those answers came from them. You know, should we not add this on as a standard part of the process? Should we not be thinking about this as a standard part of the process? You know, they started to realise the role that physical activity might have. I feel that we've spent a huge amount of our time selling physical activity as a way to achieve outcomes. I think that they grabbed that concept and ran with it really quickly. I guess it's not particularly contentious. It's a fairly easy sell. And we're potentially presenting some solutions that they don't necessarily have, and different ways of doing things. And I really feel that you know, health are really trying to look for different ways of doing things, because the old way hasn't worked, and that's why we're in such a mess. So I think the opportunities are there. I think we've got the ear of, and we've potentially got, you know, quite an innovative way of thinking that perhaps they haven't, you know, not me individually, but I think as a sector we have. and potentially have some of those solutions. So I don't think we went in with that intention necessarily. Yeah, okay, maybe influence some policy, but we didn't really know what that meant. I think that's happened organically as part of the process.
Great. Okay, that's really interesting. I figured that's the way that you described it, that was the case. So it's just confirming that. Good. Okay. Just conscious of time. It's coming up to 2 o'clock. Any final questions? There's a few things at the end of the case study around partner feedback. I think that speaks for itself. Is there anything around the learning points? Maybe it's a good way of summarising anyway, Shelley, that you'd want to pick out, the kind of key do's and don'ts?
Yeah, I guess I've sort of, as part of it, mentioned a lot of these. I think that senior commitment bit is key. I think there's been a bit of a speculate to accumulate, as part of this process here, and I think we've had to give quite a lot, which is a change in tactic, particularly with CCGs, and I think just the acceptance that it does take a bit of time. So I've got someone else ringing me, which is annoying. I've got beeping in my ear. They'll go away in a second. I think, as I mentioned a minute ago, not presenting physical activity as the solution, but as part of it, has been quite key. It has a role to play in so many things the CCGs are focused on at the moment, and I'm sure it'll be similar elsewhere. But diabetes, massive issue. Falls in Norfolk aging population, huge issue. Obviously, the raft of long-term conditions, but there is a much greater emphasis within the long-term plan and within the prevention vision. There'll be a paper for that soon, and a new social services paper coming out. And I think those things are all going to really help our case. But it's about shaping physical activity up as being part of something bigger. And I think a lot of what we were trying to do, and I know I just touched on it with Louise, was we need to just be clear about what existing resources we have and whether they're underutilised, or whether, a lot of this has been about how do we, the health system have access to the individuals that we're trying to target. And there are many things in Norfolk that already exist that have the capacity to work with those people, and maybe realign our workforce development budgets a bit more sensibly to ensure they're able to cope with people with long-term conditions. But we've got a lot of assets already in the county. So a lot of this is just about alignment of what we've already got and the existing resources, rather than we need money to do X, Y. I mean, obviously the money helps, and we need the investment to do the strategic work. And that's the case that we're putting across CCG at the moment is, a lot of this isn't about big scale investment. It's about having the capacity to do this work. And they're now paying for some of my time to continue this work for the next 12 months. That's just in Norwich. And then we're having bigger conversations with the wider system. So, I think we need that investment into our strategic capacity to allow this to happen. And I think the big thing for me is, if you can arrange any sort of, even if there's no formal agreement for a piece of work like this, actually physically spending time in other people's offices and just do it. And mutually, we offer that time back. So we have a couple of the public health team that come in occasionally and sit with us. But actually just being in the CCG and going along to a few team meetings and that kind of thing has just been hugely beneficial. And it's not necessarily detracting from business as usual. It's just about sitting at a different desk in a different office with a different group of people. But it's really helped build those relationships. You're seen by senior leadership when they come in. They know that you're, taking that time to understand their roles and responsibilities. And I think that's been really important.
Excellent. Okay. Well, I think that's a nice way to wrap it up in terms of the key learning points. I'll just open up for one final go. If there are any final questions that anybody'd like to ask? No? Okay. So let's wrap it up there. A big thank you to Shelley for, first of all, producing the case study and then sharing thoughts today via the webinar. Hopefully you found it useful and quite an efficient way of sharing practice and learning from each other as well. I will share this recording on the hub, and when I do that, that'll be a group post, so please use that as well to share anything that you've got, or obviously continue the conversation in terms of questions and what have you. And as I said at the start, if you've got any emerging practice around a particular system that you're working on within your active partnership, we'd be really pleased to speak to you about working that up into a case study. So thanks for your time today. Enjoy the rest of the day, and we'll catch up soon. Thanks, everyone.
Thanks.
Thanks, Shelley. Cheers.
Thanks. Bye.
Bye.